All right, you guys ready to begin? Let's do it. So, the epi-bio test, how'd you guys feel? Good? Bad? Fair? Okay, okay. I will say that the average for your class was higher than normal. And I did some calculations, and I found out it was statistically significant. You guys are an outlier, which means technically that to me, you're all not normal. So, congratulations. It's a good thing. No, good job. There's one high miss, no give back, so because the question was correct, but it was a question about the therapy dogs and the independent variable and what was the order of measurement. It was nominal, right? Because there's the 3 dogs. Everyone saw like that 1 to 10 scale, like it's ordinal. And you read too quick, right? It's okay. Unless you specifically ascribe an order of magnitude of difference between a Dachshund and a Welsh Corgi, but I don't really do that, so it was all nominal. Anywho, so let us continue on. Any questions from the other antiarrhythmics we talked about so far? So we're talking about class 1 antiarrhythmics, and what was their main mechanism of action? Sodium channel blockade, correct. So we have class 1A, which included which 3 drugs? PDQ stands for Flecainide, disopyramide, quinidine. Yes, absolutely right. So those are your 1A antiarrhythmics. And then we had our 1B, the main one we talked about there is? Lidocaine, good, right? So what was the thing that differentiated lidocaine from your class 1A antiarrhythmics? It worked better like in ischemic tissue, so it was good for like a patient had an MI and they're developing like a ventricular arrhythmia secondary to that ischemia or infarction. So that was one thing that's kind of different with that. Now we have our 1C antiarrhythmics, and so it's going to include Propafenone. And I gotta remember the other one now. I'm sorry, my children have been sick all night, so I may be a little spacey here, but they're okay. They were just being brats. Yeah, it is what it is. So anyway, so we have the 1C antiarrhythmics, and so these are also going to be slowing down phase 0 of depolarization here. They're going to prolong that refractory period, so make it basically make it harder for those cells to have the reentrant arrhythmia actually develop there. And so again, their dissociation and channel affinity is going to be a little different than what we saw with the 1A or B. So Flecainide and Propafenone is the other one we're going to be seeing in this group here. And so also interesting is that this Flecainide itself blocks sodium channels as the main mechanism, but also has some activity blocking potassium channels in the ventricles. Anyone know what that does for us? We've talked about this before in terms of medications like azithromycin or the fluoroquinolones. QT prolongation, right? Why do we see QT prolongation? Blocking those potassium channels, right? Potassium efflux is one of the main things that causes that repolarization phase to occur. And so, again, that will also prolong that QT, right? And anytime you're prolonging the QT, what do you run the risk of? Torsades, right? So these are always going to be risks with these medications here is, again, they're monkeying around with how the electrolytes are shifting, thus you're going to see arrhythmias being a potential risk there, right? So again, you're going to see PR, QRS, QT intervals all going to prolong with this one. It has a pretty long half-life. We have oral and IV options that are available, but this is, you guys ever heard of the term pill in a pocket? I believe Professor Kaplan might have mentioned it once. This is one of those type of drugs where basically if some patients feel like they're about to have their AFib come on, or they start to feel those palpitations associated with AFib, they can take one of these tablets and just go ahead and try to eliminate that. So basically you're causing them to have their own chemical cardioversion by taking a tablet. What do you think are some risks with doing that? So like how compliant is your patient going to be with that? Do they actually know themselves well enough? Are the patients that are likely to have things like big shifts in electrolytes, maybe due to kidney issues, maybe due to dietary issues? So you had to really do it in patients who are really going to be compliant, fairly stable patients. And so we started to kind of move away from that. And so instead of using that rhythm control to try to put them back in a normal sinus rhythm, we started to focus more on the rate control, which we'll talk more about in the beta blockers and calcium channel blockers coming up. They also did some studies and actually found there's increased mortality when you try to use this pill-in-the-pocket method. So it's less popular. However, you will still see some patients that will undergo this. So again, they'll feel those palpitations, feel the AFib coming on, they'll go and take this and then put them back in normal sinus rhythm. So that's what they mention, or when they see pill-in-the-pocket, that's what they're talking about. And again, we could use this for life-threatening ventricular arrhythmias, supraventricular arrhythmias, because again, by blocking the sodium channels, they can work both on atrial and ventricular tissue. not necessarily on the nodal tissue, but on the slow response or the fast response cells, I should say there. But again, not to be used in patients with significant damage, because again, by changing those refractory periods, you could put them more at risk for developing an arrhythmia. So in terms of Flecainide, the biggest toxicities we worry about are going to be these things like ventricular tachycardias. Now, actually, one time I had a patient who had called up, basically it was EMS calling us at the poison center and said it was a guy who had congenital heart defects and had a whole bunch of open heart surgeries and stuff, but he was on Flecainide for prevention of arrhythmia, and he actually ended up trying to overdose himself and actually took a whole bunch of it at the same time. So if you had a patient like this who was blocking all the sodium channels, what do you think you could do to try to reset them? Actually give a whole lot of sodium, right? So we'd actually give a lot of sodium bicarb, and that can actually help to kind of reset that. So if you ever see someone's got QRS prolongation due to the sodium channel blockade, very frequently we give sodium bicarb to try to shrink that back down. But anyway, so those are things to consider there, because they can be really tricky to treat, because once those sodium channels are blocked up, it can be difficult to kind of reverse that effect there. Other things you may see include things like bronchospasm, maybe some seizures, especially if the patient isn't able to clear it that well. And again, if we've tried to use it in things like MI before, with ventricular arrhythmia secondary to MI, and we actually found increased mortality, so that one you're not going to see used too frequently there. Similar to Flecainide is going to be Propafenone, very similar activity. This actually has some additional beta blocking activities. What do you think it's going to do for us? Slow down the rate, so you may find it maybe a little bit more beneficial, say for like AFib or something, where you're having that fast conduction down into the ventricles. That could be good. But again, any of these can be proarrhythmic, so be aware of that. But there's also non-specific beta blockade, so who am I worried about that in? As asthmatic patients, you'd worry about that, right? Also, some riskier things like agranulocytosis, anemia, thrombocytopenia. So there is some bone marrow suppression that can happen with this. And again, another reason why these drugs don't get used too frequently, but occasionally you'll still see that. Why do you think you see worse in CHF? It's that beta blocking activity, right? Just decreasing cardiac output, so it can potentially uncover or cause an exacerbation for those patients. Okay, so those are the class 1 antiarrhythmics. So kind of keep the differences in mind between the 1A, 1B, and 1C. 1A and C, kind of similar activities. You're going to kind of see similar indications for both of those. 1B, as we mentioned, lidocaine, kind of think about that being used for ischemic tissue, being a little bit better for that. Now we're switching gears a little bit, go to class 2 antiarrhythmics, and these are mainly just going to be the beta blockers, right? And so what would you expect to see on the EKG by administering a beta blocker? Slower heart rate, right? So you'd probably see sinus brady, if anything, is probably the most common thing, but certainly can induce heart block potentially, right? Various degrees of heart block, but those are kind of the most common things you're going to see with that. So instead of something blocking the sodium channels and doing what we call rhythm control to try to get the patient or keep them in normal sinus rhythm, this patient's here, if you have AFib, you may still have the atria still just contracting away, but by using a beta blocker, what does that do for us? It slows that conduction down through the AV and SA nodes, right? And that will prevent that rapid conduction to the ventricles and keep the ventricular rate relatively normal, right? So that's what we call rate control, okay? I don't really care what the atrias are doing, as long as you keep the ventricles pumping effectively, everything's good to go, right? Because again, what's the main force that fills the ventricles during a normal cardiac cycle? Is it the atria contracting? No, it's just gravity, right? It's just the fact that the ventricles are opened up and then gravity allows the blood to flow in. So even if the atrias are not working that efficiently, the ventricles still need to be the primary mover and shaker there. Does that make sense? Hopefully. Okay. Anyway, so you're going to see prolonged AV conduction, you're going to see that decreased automaticity, and ultimately you're going to find that decreased phase forward depolarizations. There's a longer period of time before you have those slow response cells actually trigger off, right? Do you remember the difference between a fast response and a slow response cell? You guys ever heard of that terminology before? Sorta. So it has to do with your nodal tissue versus kind of just the rank and file sort of myocytes, right? So if you imagine like the nodal tissue, they have those leaky sodium channels. Has ever heard of that, right? So they're slowly allowing sodium to flow in, and then once they hit that critical threshold, then they trigger off an action potential, right? Versus all the rest of the myocytes, what do? They just sit at that resting membrane potential, and they wait for someone to come along and trigger them off, usually that nodal tissue, right? So again, that's how we keep things in terms of electrophysiology working normally, is that the nodal tissue has all that automaticity, and then we allow the fast response cells, the ones that are just kind of sitting there waiting for a trigger, to only respond when they get that signal coming in from that nodal tissue, okay? So we call them the slow response cells because they have slow sodium influx, and then they hit that threshold and have an action potential. The other cells respond very quickly because they are just kind of sitting there at the ready. As soon as an action potential comes along, boom, they fire off. Okay, make sense? Okay. Anyway, so the beta blocker is good for that rate control here. Propranolol, we talked about most of these, right? So we already know what side effects we're worried about with beta blockers. So for instance, like what's kind of unique about propranolol versus some of the other ones? Like nightmares, ultramental status in elderly patients. Why is that? Why do you see that? Very lipophilic, which is also why it's pretty good antiarrhythmic too, because again, it's lipophilic, can get into the heart and kind of work and do its thing there. But again, we're expecting to see slowed AV conduction. We're going to see negative inotropic and chronotropic effects. So again, be careful in patients like CHF, be careful in patients with asthma, etc. Also, what's kind of nice here is that propranolol can also have like some membrane stabilizing effects. That can also help with the antiarrhythmic sort of activity there. So that can be another beneficial effect. And of course, for here, do you think we would use a beta blocker to help control, say, VFib or VTAC? Yes or no? Well, no, right? Because again, what sort of tissue are they working on? Working on the nodal tissue, right? So they don't do anything specifically to affect the ventricles and how they are conducting electricity. They're really only affecting that signal transmission from the atria down to the ventricles. So just slowing that pathway down. And so if you had someone in VFib, giving them beta blockers is not going to make their situation worse, right? Because you typically want that nodal tissue to be the thing that's kind of setting the pace of the heart, okay? So in these cases here, this is not going to be good for cardioversion for a patient, as opposed to something like, say, one of the 1A antiarrhythmics would be good for that, because they directly affect the sodium channel influx through those cells, okay? Does that make sense? So you see class 2 and class 4, your beta blockers and calcium channel blockers specifically, are going to be good for supraventricular arrhythmias, whereas the 1s and the 3s, so sodium channel blockers, and we'll see our potassium channel blockers, are going to be good for atrial and ventricular arrhythmias. So it's a good rule of thumb to remember for that, okay? So if I say a patient is in SVT, supraventricular tachycardia, which one of these agents would be appropriate? And a beta blocker would be a good answer for that, right? Because it can help slow down that rate there, okay? Anyway, other indications, if you have a patient who's got an MI, we know beta blockers are beneficial for them as well. Obviously, if they're already bradycardic or hypotensive, then you'd avoid it. But for those that are hypertensive, it could be a good thing to start then. And of course, we know the toxicities that are inherent with these drugs here. If I had an asthmatic patient, what could I use instead of propranolol? Metoprolol, atenolol. What's a good IV agent we talked about? It's really short acting. Yeah, Esmol is a really good one. Brevibloc is the brand name for that one. And again, it's a very short half-life, and we actually run that as a continuous infusion. So Esmol is a good cardioselective beta blocker that can be used that way. So I mentioned metoprolol, acebutolol, certainly atenolol. Any of them would fit into this category here. Just know it's less bronchospasm, but again, still the same sort of side effects, same sort of contraindications you'd expect to see, just that one difference there in terms of beta selectivity. Okay. Okay, so now we get to some more new medications here with the class 3 antiarrhythmics, and these are going to mainly be your potassium channel blockers. As we mentioned, it's going to block or prevent that repolarization from occurring for at least a longer period of time. So whereas you saw the sodium channel blockers, what did it do to your phase 0 depolarization? Remember, it reduced it, the overall height of the curve, and then what did it also do? Slowed it down, so it shifted it over to the right some. Notice here what's happening. It's just that repolarization phase that you're slowing down. So again, remember what's causing this plateau here? It's calcium coming into the cell, right? And so we're actually, at this point here, you normally start to see potassium channels open up and allow that to flow out to repolarize. Instead, what we're going to see is that we're going to slow that down, and thus is going to prolong the repolarization phase. And what does that do to the refractory period? Prolongs it, right? It's going to be a longer refractory period, so that way it's going to be harder for that reentrant arrhythmia to affect one of these cells, okay? You have to talk about absolute versus relative refractory periods. What's the difference? So absolute means that nothing can come along and re-trigger that cell, right? So this is going to be early on, versus the relative refractory periods. If you have a strong enough signal come along, you can then trigger off another action potential, right? So towards the tail end here is where we're going to see that relative refractory period kick in, versus earlier on it's more of the absolute refractory period, okay? So that's a just point of knowledge there. And so the main one we're going to see used here is going to be amiodarone, or Cordarone, Pacerone, the two of the brand names here. Amiodarone is really kind of interesting because it's actually an analog of thyroid hormone. You can actually see, anyone know what metal is needed to produce thyroid hormone? Iodine, yeah. And you can actually look here on the amiodarone, you can see the iodine molecules kind of sitting on there, right? So it looks a lot like thyroid hormone. Metal? Yeah, iodine's a metal. On the periodic table, right? Yeah. Sodium's a metal, technically speaking. We will consult our periodic table of elements at the break. We'll find. No, I'm just kidding. No. Well, they need that ion. How about that? So we need an iodine ion in order to form this, and so does our thyroid hormone, as it turns out. So anyway, so we're going to find that what kind of side effects would you expect to see because of that? You might see hyperthyroidism depending on the situation, right? So we're going to see some of the side effects that can come about because it structurally looks kind of similar to thyroid hormone, right? Anyway, so this is really starting to take over as being kind of like the go-to agent in terms of ventricular arrhythmia management. And so actually, if you look at the ACLS guidelines, they used to say, well, you can either use like lidocaine or amiodarone. Now they just really say, just go with amiodarone, maybe lidocaine as a backup if nothing else is really working for you. Obviously, if a patient's in cardiac arrest, what's kind of the best thing for them? If they're like in VFib or VTAC, anyone know? Yeah, shock them, right? They use electricity to put them back in normal sinus. However, if that doesn't work, then you can utilize something like amiodarone. That's kind of your go-to antiarrhythmic for chemical cardioversion in those cases there. We have oral and IV availability, so we have some patients are on this long term, start them off in the hospital, convert them over to oral, as the case may be. So you notice the half-life here, pretty long, 40 days, but it can range anywhere between 26 and 107. What do that means in terms of, say for instance, time to steady state? How long does that take normally? 4 to 5 half-lives, right? So you want to give the patient like 200 days to get to steady state if they have a ventricular arrhythmia right now? It's not compatible with life. They might be decomposing by the time the drug gets to steady state. Or they'll stop metabolizing at some point, and then it won't matter. Because their liver's dead, along with the rest of them. But how do you get around that? What do you do? Loading doses, absolutely. So this is another really good example where you have to use a loading dose to get the patient up to steady state level, so that way the amiodarone is there blocking those potassium channels, prolonging that refractory period, and hopefully interrupting that reentrant arrhythmia that is causing, or that reentrant signal that is causing that arrhythmia to occur there, and it will help to terminate that. But that also means there's a very slow elimination, very slow offset. So even if you stop a patient, they've been on, say, for 10 years, and you stop them on that drug, it's going to last a long time, right? Which can be good for some purposes. And you imagine if a patient has poor compliance, right? How's that benefit us? They still have pretty good levels sitting around there for a good period of time, right? Also, it means that they're having toxicity from it, guess what? It's going to be hanging around for a long time too, right? So there's kind of a double-edged sword in terms of that, depending on how the patient's responding to it. But when do we use it? Basically for recurrent ventricular tachycardias or fibrillation. You can also use it for atrial cases too. It's less common, but certainly could use it for either or, because again, it's affecting the same potassium channels, no matter where it's at in the heart there. And we'll use it very frequently as an alternative to, if you have a patient like, say, for instance, has an MI, oftentimes we will still go with amio as our first kind of go-to and for VFib or VTAC very frequently. So it's kind of replacing lidocaine in that case there. So what it's going to do actually has a lot of other mechanisms than just blocking potassium channels. It can do things like block some inactivated sodium channels that may have some effect on QRS, block some calcium channels, alpha and beta receptors. So there's a lot of different things that are going to be happening here. And that can induce some of the side effects that we're going to be seeing here, but also has to do with some of the therapeutic effect and helping to terminate that arrhythmia and keep them in normal sinus rhythm. So the toxicity here, you might expect. So we said they affect alpha receptors, right? So if it blocks alpha receptors, it causes what? Hypotension, right? Because your vessels are going to dilate. So that's certainly something to be concerned about. If a patient is in VFib, VTAC, what do you think their blood pressure is doing anyway? It's probably not very good, right? So that may be a concern there where you try to get them, get the ventricles working again, but then you have to worry about the hypotension they're developing. So again, sometimes you have to use additional treatment like fluids or pressors and things like that. We'll talk about those later. Other things that are notable here, and this is going to be more so with kind of long-term chronic therapy where the drug is building up levels over a long period of time. You can see things like pneumonitis and pulmonary fibrosis, which has been fatal in some cases, right? So again, just that kind of chronic over the course of many years that this develops. You see some neuropathies and neurotoxicities. Also, another interesting thing is you get this blue-gray sort of skin discoloration can happen there. And again, because the drug lasts so long, if it is reversible, sometimes it takes a long time for that to occur as the drug sort of slowly eliminates from the body. So one thing to note, some corneal deposits, and then we mentioned the thyroid can either go up or down depending on kind of what their resting level is potentially. So that's one thing to note with that. Some hepatic dysfunction, a lot of issues here, and then there's going to be a lot of drug interactions as we can see. So looking at all this toxicity, why do we use the drug? It's really good at what it does, right? So in some cases there you got to balance the risk versus the benefits, and if it's good at what it does, then let's stick with that, right? And it's kind of an old drug. We've been using it for a very long time. We're starting to see some alternatives, which I'll mention a few here in a second, but it's just one thing to know that it's still a go-to in a lot of cases, especially in the hospital. So as an alternative, that you have things like Dofetilide, which is Tikosyn. This one's a little bit newer, and so this is just a pure, strict potassium channel blocker. And so in some cases, we're actually using this as an alternative to amiodarone, especially for more long-term therapy, because this lacks a lot of the kind of chronic side effects you see with something like amiodarone. And so again, it can be used to maintain sort of normal rhythm and atrial fibrillation. However, this is one of those ones, if you recall, we haven't talked about dermatology yet. Have I mentioned REMS programs before to you guys? So there are certain drugs that are extremely dangerous for one reason or another, such that the FDA mandates to have a special program to go along with it. It's called a risk evaluation and mitigation strategies, and basically it's for certain drugs, it's like you have to make sure people who take it are getting regular pregnancy tests, or people are taking or having CBCs monitored regularly. This is one of those ones where you have to have really special training to where the providers signed up with the program, the patients signed up with the program. Sometimes the pharmacy has to be signed up as well, because this could be a really big risk for causing something like torsades, because it is just a pure potassium channel blocker. And so because of that, you don't want to send this, give it to the wrong patient, send them home, because they could just go into torsades and die, right? And so this is why you have to make sure to monitor things like their electrolytes, which is really important. So for instance, if they had hypokalemia, that could exacerbate that efflux of potassium there. It could affect that. It could lead them more likely to have an arrhythmia, right? They have hyperkalemia, that can also affect things as well. Hypomagnesemia, hypocalcemia. These are all things you have to watch for, because it can affect the likelihood of them developing torsades. And again, you'd be monitoring what on the EKG, specifically in this case? QTC, right? And what's a normal QTC? It's like 440 for men, like 450 for women. Typically, it can range pretty widely depending on the patient here, but this is certainly one of those things where if you start to see 500, 550, it's going to prolong, but you really have to watch that, because the longer it gets, the more likely they are to develop that torsade. So it's something to watch out for. And again, this is only eliminated by the kidneys, so you do have to watch out for that renal function, make sure you're dose adjusted, or maybe some patients just aren't a really good candidate for it at all, right? In these cases, if they couldn't tolerate Tikosyn, you probably put them back on something like amiodarone instead, which is more hepatically eliminated. We also have Sotalol. You say, wait, Sotalol, what kind of drug is that? That's a beta blocker. What's this doing in class 3? I obviously must have misplaced my slides. I did not. Actually, sometimes I will misplace slides, or if you ever see I have a hidden slide and I didn't talk about it, it's probably because I don't even know it's hidden and I just kind of glossed over it. Make sure to mention that to me, please. I don't know, I have gremlins or something that cause slides to be hidden. I have no idea how that happens, but or I have gremlins at home that go and start typing on the keyboard. A 3-year-old and a 1.5-year-old, you know how it is. Or you might know how it is one day. It's fun. So anyway, Sotalol is a beta blocker, yes, but it also has some potassium channel blocking capabilities as well. So it kind of fits this quasi class 2, class 3 sort of classification here. I'd lump it more into the class 3, and we will again see this used for AFib, a flutter, or to treat tachyarrhythmias in the ventricles. Any of them would be totally fine there. This is frequently, I see this more in patients who have a congenital prolonged QT. They may be on this potentially to help manage that, or some other arrhythmias they might be on. So it just depends on the case there. This is going to be a little bit more specialty sort of cases you'd be using this. Wouldn't be sort of one of your go-to beta blockers for the majority of patients. Again, obviously you still worry about the bronchospasm, the beta blocking capability, but torsades obviously being the big risk with any of the class 3 antiarrhythmics here, right? Then we have our class 4 antiarrhythmics, and I say calcium channel blockers, but which ones am I specifically talking about? DHPs or non-DHPs? Non-DHPs. So we're only specifically talking about Verapamil and Diltiazem in this case here, right? Why is that? Because they're going to work similar to the beta blockers in terms, not the same mechanism, but in terms of having negative inotropic and chronotropic effects. Certainly they're going to have very similar activity in that case there. So again, they're blocking the L-type channel. They decrease the automaticity. You can see very similar effects on the heart as you would with the beta blocker, right? So if you had a patient who was maybe precluded from getting a beta blocker for one reason or another, this is a decent alternative to that, right? You can certainly put them on one of these. And certainly, if we have patients who have, say, SVT or supraventricular tachycardia, oftentimes this may be one of our backup agents. I'll talk about the go-to agent in just a few minutes here, but sometimes we'll actually use this as our backup in order to help get the heart rate under control there as a form of rate control. But again, they're working on active and inactivated channels here. They're very effective in the more active tissue, which in the case of SVT is going to be that nodal tissue. It's very rapidly conducting that signal down to the ventricles, which makes sense. That's why it's really good for that. Remember what our Toxicities are going to be with Verapamil, Diltiazem. What could you see? That's a patient if using chronically, right? What about more in the acute phase? Actively treating tachyarrhythmia. It's like hypotension, right? Because they'll dilate the arteries, right? You can see that. Certainly, edema may develop because of that in certain patients. Obviously, be careful, like in CHF patients. These are all things you want to be, certainly cautious with. And again, would this work on ventricular arrhythmias? No, because it's really only working on suppressing that nodal tissue, right? Now I have a couple of miscellaneous agents, some of which we've talked about, some we have not. So the first one's adenosine. Has anyone ever seen adenosine given? How cool was it? It's pretty quick, right? Pretty cool. I'll tell you why. So adenosine, we have adenosine receptors kind of located throughout the body, and I kind of think about adenosine as being like the emergency brake on your car. So if you need to stop really, really fast, you probably pull your e-brake, right? And adenosine kind of does the same thing. And so here what you're going to find is that it will activate potassium channels and then blocks calcium channels. So basically you block calcium from coming into the cells, and then you cause all the potassium to flood out of the cells. So basically it stops all electrical activity for a very short period of time. That sound like it's a good thing for your patient? Not for the long term, right? Because then they're dead. But if we do it for the short term, it actually works out pretty well. So it's kind of like, if your PC's not working, like what do you do with it? You turn it off and turn it back on again. That's essentially what we're doing here. And it's really neat when you're watching this like continuous EKG when they do that. So it really hyperpolarizes the cells. The benefit though is it only has a very short half-life, only about 10 seconds or so. By the time you get it into the patient, stops the heart for a second, and then heart comes back on once the drug gets metabolized away, and then boom, you're good to go. Okay. Hopefully the patient went back into normal sinus. Most of the time they do, sometimes they don't, and then you have to figure out what to do from there. But basically it will decrease that automaticity, prolong that refractory period for just a very short period of time. And so we'll use this typically in cases of paroxysmal supraventricular tachycardia. So PSVT is probably the most common thing we'll use. If a patient comes in, they're in SVT and they're trying to Valsalva and that's not working, use ice packs and that's not working. This is usually what we end up going to as kind of our first line chemical agent here to try to put the patient back in normal sinus. Parkinson White's another one you may see it used occasionally. And so basically you'd hook the patient up to a 12 lead, kind of running a continuous 12 lead strip, and then basically what you end up doing is you push the medication. Now, how fast do you think you have to push this? Extremely quickly, because by the time, if you just kind of leisurely push it in, all the drugs metabolize before it ever gets to the heart. And so what you end up normally having to do, I don't think I have a picture of this, but we have call it a stopcock method. You guys are familiar with a stopcock? Use them in a lab. A three-way stopcock. Basically, oh boy, I'm gonna start drawing. Essentially what it looks like is you're going to have one end here, you're going to have one end here, and then you have the other end going to the patient, right? And so you have like a little knob here that will be able to turn off one of these or none of them. And so this is going to be hooked up to the drug on this side here. You will then, what do you think you have? So you have a drug on this side, you have the patient on this side, and what do you think you have sitting here? You have a saline flush, right? So basically you have this method where you can push the drug in really quick, the saline flush goes immediately after, and then all of that should get through the venous system back to the patient as quick as possible. The problem though is that people, one, can't figure out how to use a stopcock because they'll put it in the wrong direction and then it'll close off one of them. Not smart. I will not admit to doing that at least one time in my life, but anyway. So either they do that or they push it too slowly, in which case the drug is all metabolized off by the time it gets to the heart. And so in those cases, if the first dose doesn't work, we end up doubling the dose and trying to give it again. So by the time they double the dose, at least some of it gets there and it actually works on the patient. But you'll essentially push it really fast. The patient looks like they flatline for like a couple of seconds. They're still conscious, and then it should come right back to normal sinus. Should it work? Otherwise, it'll go back right into SVT. So it's very interesting if you ever get to see it there. But as you might imagine, there's a lot of side effects associated with that kind of in the short term. So they get like really flushed, you can have shortness of breath that's not very comfortable, a lot of burning in their chest, right? There's a kind of a unique one described. It's called this impending sense of doom. Like it's actually in the package insert, which I always thought was kind of an interesting side effect. Like you guys probably feel that at least every Monday, Wednesday, Friday for the most part, right? So maybe you're all getting a heavy dose of adenosine. We'll sometimes use this as well, like if you work in a stress, anywhere they're doing like cardiac stress tests, they actually can give adenosine to kind of stress the heart out to look to see if there's any EKG changes and things like that. And so it's interesting, I was talking to a student one time, they said, yeah, I was wondering why we give the patients caffeine, like tea or coffee or something like this after we give adenosine. And I was like, oh, I know why they actually do that. If you actually look at the mechanism of things like caffeine, like tea or coffee or anything like that. It actually is an adenosine receptor antagonist. They actually will give it to the patient after they got adenosine to try to kind of reset them a little bit, even though the drug's probably all metabolized off anyway. But so again, that's kind of how we use adenosine. It's kind of the most common sort of purposes, at least in the ER setting is where I see it. Now we talked about digoxin, right? What do we use that for previously? Well, like 2 days ago. It's like CHF. Most common thing you'll see used for. Remember those neurohormonal effects. Now we're kind of more focusing on it in terms of its activity as an antiarrhythmic, right? Again, not used super commonly, but however, it does have the ability to kind of inhibit some of the calcium channels and AV node. Remember, it also is working to block that sodium-potassium pump, right? So again, that's also helping to prolong the refractory period to some degree there. And so other big effects, so it's going to help to increase parasympathetic tone, so more vagal tone on the heart, which kind of slows it down, and decreasing sympathetic tone. So the kind of a myriad of different things it can cause here. Remember who you got to be careful about using this in, right? So who are some patients that should be cautious in using digoxin? Have hyperkalemia, have renal dysfunction, things like that. And so again, we know the side effects that are kind of very unique to digoxin. What were those? Yeah, yellow, green halos around lights. What do you call that? Xanthopsia, right? You gotta know the fancy words so you can impress all your friends, right? But anyway, so again, be careful and use this in conjunction with things like calcium channel blockers, beta blockers. You will get sort of a synergistic negative inotropic effect, and it can either induce heart block, you can see induce poor cardiac output, things like that. And then last we have magnesium. What do you use magnesium for? Torsades. This is the treatment of choice for torsades. This is like a very easy classic board style question you may get one day. So mag sulfate is going to be a treatment for torsades. Anyone know why we do that? So magnesium is kind of like the body's natural calcium channel blocker, and so by administering this, it helps to kind of reset things to some degree. You basically just give a big dose of 1 to 2 grams very quickly, and that will help to reset the heart and go hopefully terminate that torsades arrhythmia. Things to watch out for, because it acts as kind of like a natural calcium channel blocker. Hypotension and flushing is a big thing you're going to see with that, so do be careful. In that term, oftentimes we'll get that along with fluids to try to help replete the intravascular volume to help prevent that flushing and hypotension from occurring there. Okay, so again, that's another common one you may see. We'll see this used in a crash cart pretty frequently. Everyone know what a crash cart is? What is that? Yeah, like a rapid response cart. Basically has all the equipment and drugs you need to run a code anywhere. So it'll have, sometimes it'll have the AED attached to it. It'll have, supplies, syringes, all that kind of good stuff. But the medication aspect of it, if you go to, like on clinical somewhere, like try to get familiar with that, because you never know when you might need to respond to a situation. It's going to have like your epis, it'll have atropines and calcium and magnesium, all kind of good stuff. It's good to get a kind of familiarity with it. We'll talk more about that next semester when we get to the ER section. Any questions so far? All right, let's do 10 minutes. We'll come back and then start on the pulmonology section. All right, let's talk about some pulmonology. So we finished all the cardio stuff, thankfully, right? Let's get into talking about the lungs, and we're getting to go back to antibiotics. Yay! Fantastic. And guess what? Benko's going to make a return, so we'll at least have some right answers for sure. Right? I know my crowd. Anywho, so start off with bronchitis, right? So we'll kind of work our way down the respiratory tract here. So again, initially here we're seeing this inflammation of one or more of the bronchi, right? We're not really talking about like kind of the deep portions here of the bronchioles and things. We'll get to that when we get to talking about pneumonia in just a few minutes here. Certainly, what's the main etiology for a lot of cases of bronchitis? Most of it's viral, right? So again, this is another case where we frequently overprescribe antibiotics for this, and so look at some cases where maybe appropriate, maybe less appropriate. Certainly for more chronic patients, chronic bronchitis, that's where you think about your COPDers. We'll talk about that later on in the section. And so, as I mentioned, common causes tend to be viruses, rhinoviruses, coronaviruses. Certainly for influenza, is there anything we can do about that? Any drugs we might have talked about? You test flu A or flu B in your 48 hours within that window. Oseltamivir or Tamiflu, right? So certainly can do that, which is important because we're getting close to that season, right? Flu blitzes at hospitals are already starting. They haven't gotten their flu shot yet. I'm waiting to get mine. I've been delinquent, so please don't infect me in the meantime. Anywho, but yeah, mostly that's just all going to be supportive care for a lot of those patients, unless they have a clear indication for something like Tamiflu. When it is bacterial, though, and sometimes it'll be sort of like a bacterial superinfection on top of the initial viral infection, that's where we can start to see more atypical bugs kind of enter into play here. So things like Mycoplasma, Bordetella pertussis, things like that. Certainly, we'll still end up seeing sort of the common upper respiratory bugs make their way down. So strep pneumo, H. influenza, Marxella catarrhalis, all those are going to be potentially playing a role as well. And again, oftentimes it's a secondary infection on top of the viral one. So for the most part, we just treat them supportively. If they have fever, what do you give them? Acetaminophen, what else? Ibuprofen, right? So kind of common over-the-counter stuff is fine. If they, if they are coughing a whole bunch, what can you give them? So dextromethorphan could be good, right, as a cough suppressant. If that wasn't working, what could you use instead? Benzonatate or like Tessalon pearls, right? These are all things to consider, right? We typically will avoid using antihistamines because what kind of effect does antihistamine have like on fluids? Usually dries things out quite a bit, right? Remember the dry as a bone mnemonic we used as part of the antihistamine effects? So because of that, that tends to dry out those bronchial secretions, and that makes it more difficult to expectorate them. And so in those cases there, you have kind of that gunk just sitting around, which could also get infected itself. And so to prevent that, we say, hey, drink lots of fluids, maybe avoid the antihistamines, and try to get rid of that junk as it kind of comes up, right? And so we don't routinely give out antibiotics to these patients. However, I mean, some people routinely give out antibiotics to these patients, which is inappropriate. But you're all going to be good PAs, and you won't do that, correct? I believe so. I'm 95% confident that 63 good PAs will be practicing in a couple of years, right? Anywho, so oftentimes there'll be a lot of unnecessary prescriptions. Sometimes you may say, hey, listen, maybe in a couple of days, if you're still not feeling any better, you hand them a script to fill at a later time. Again, that kind of comes with pluses and minuses because patients feel like you did something, but then they may go fill it prematurely anyway. Typically, if they have persistent symptoms, say greater than 5 days, that's when you want to start consider bacterial involvement for those patients there. And so what do you notice about the drugs we're going to be using for these patients? Because for the upper respiratory stuff, we saw a lot of amoxicillin, we saw a lot of Augmentin, we saw a lot of Clinda, first generation cephalosporins. What are we seeing here? So like doxycycline, what kind of drug is that? Tetracycline, good. We have macrolides we're using here, potentially fluoroquinolones, like what? There's some fluoroquinolones. Ciprofloxacin, levofloxacin. So you notice that the drugs we're using are changing up a little bit because we have to account for what type of bacteria. Atypicals, right? So that's why you're going to be busting out things like your doxycycline, tetracycline, your macrolides, respiratory fluoroquinolones, things like that. Now, I would hesitate to use a respiratory fluoroquinolone for these patients here, kind of hold off on that because you are starting to see more and more resistant strep pneumo. And if you're working, say, in a hospital or somewhere, how would you determine what kind of resistance patterns you're seeing in your area? Remember that antibiogram? Yep, so most students don't ever have heard about an antibiogram, but you'll be astute PA practitioners and you'll be going into your rotations and say, hey, do you have access to an antibiogram? And then maybe you'll get a copy and you can see what kind of patterns you see depending on where you're practicing at. Or you won't do that and then you'll just forget about it like most of the other stuff I'll teach you, but that's okay. You at least have heard about it at some point, so if someone mentions it, you'll know exactly what it is. So that's bronchitis, kind of moving into community-acquired pneumonia. Or CAP, right? We're going to see that frequently bacteria can get into the respiratory tract because normally the respiratory tract is sterile, unsterile. Most of the time it should be pretty sterile, right? Because we have these nice ciliated cells that can move kind of stuff out of the lungs, keep it pretty clean for the most part. Certainly we can see things like aspiration from the oropharynx can be a cause for bacteria to get down to the respiratory tract. What do you think you see that more in the elderly? Decreased mentation, maybe they have dysphagia because of Parkinson's, things like that can make it easy to have these micro aspirations. That can introduce bacteria down in there. Certainly if you're inhaling infectious particles, sometimes infections can start off maybe like a UTI that has more of a hematogenous spread, then gets into the lungs, lots of different reasons for this, why we get these bacteria here. And so when we're looking at patients with community-acquired pneumonia, we're going to see that a lot of the selection in drug therapy is going to be dependent on kind of how sick they are. And in terms of how sick they are, are they going to be outpatient managed? Are they going to be coming into the hospital? Do they need to go to the ICU where they get the highest level of care? Usually it's going to be indicative of what kind of bugs might be present and then what kind of antibiotics we need to use. So obviously if they're able to, say, be dispo at home, Do you think our antibiotic coverage is going to be pretty wide or pretty narrow? A little more narrow, right? Versus they're going to the ICU and they're septic, probably pretty broad, right? We're going to be kind of covering all our bases at that point there. So typically a lot of these patients are going to be candidates for outpatient therapy, do pretty well with empiric antibiotics. There's not really a lot of need to do other further diagnostic tests like cultures and things like that. Most times they just don't need it. However, if the patients are going to be coming in-house, they're sick enough to require that extra level of care and observation, you probably want to go ahead and get blood and sputum cultures in those patients there, right? Why do we care about blood cultures for someone we think has pneumonia? Yeah, it could be some hematologist aspects to it, right? And so we may need to change drug therapy depending on that, who can say. But the sputum cultures, what are some drawbacks to using those? Frequently contaminated, right? So like you would get like a sputum culture and it's a bunch of epithelial cells in there. It's basically just spit at that point, right? And we know we have all kinds of stuff growing in our mouth anyway, which may not be the actual pathogenic bacteria that's causing that pneumonia. So again, it's controversial, but typically you'll get a gram stain and a culture started there. Gram stains can be useful because it will tell you right off the bat, you're dealing with gram positives, gram negatives, and that can tailor your therapy to some degree there, right? But again, the responsible pathogen may not always be found, because what if it's an anaerobic bug, right? You have to do specific anaerobic cultures for those kind of patients there. So looking at the type of bacteria you're frequently going to see in both outpatient and inpatient and say ICU level of care, you can see it kind of changes a little bit. So for the outpatient, you see a lot of the strep pneumo, see a lot of those atypical bugs here, kind of the normal stuff that we saw with like the bronchitis, right? However, when you start to go more inpatient, now you can start thinking about bugs like Legionella, aspiration, bugs coming up from the GI tract potentially. Now, if a patient does have a history of aspiration, say they were like CNS depressed due to drugs or something like that, and they vomit and aspirate, do they really get like an anaerobic infection because of that? Because you do a chest x-ray and they're having respiratory symptoms, chest x-ray shows infiltrates. That's not always actually an infectious cause. Anyone ever heard of a chemical pneumonitis? Imagine your stomach acids, they're pretty caustic stuff. Imagine if you got that in the lungs. Is that going to cause some inflammation, irritation, fever, spike in your white count? It'll do that, right? So that chemical pneumonitis is frequently a reason why patients look like they have a pneumonia when really it's just more of that inflammatory process there. Do you need antibiotics for that, you think? No. So very frequently, this is something I always saw like a lot of residents doing. They'd always get berated by their attendings on rounds, is they would say, oh yeah, patient got admitted overnight, they had thrown up, they aspirated, we went and started them on. What's a good drug that will cover anaerobes? Not gentamicin necessarily. So anaerobic bugs, it's like Clinda could do it, ampicillin, sulbactam, right? So they'd always start them on Unison, which is ampicillin and sulbactam, and the attending would always yell at them every single time. Like, what are you doing that for? They just have a chemical pneumonitis. It's not actually an aspiration pneumonia, okay? So don't make that same mistake, okay? I'm telling you now. Just like don't say bun when you're reporting out labs, and don't start every patient who aspirates on antibiotics. Anywho, getting back into the ICU, now you're going to start to see some of the more serious bugs we're concerned with, things like Staph aureus, which what kind of drugs are we going to use for that? Perfect. And then now we're starting to get more into our gram-negative bacilli, right? So you can start to see those enteric gram-negatives. This is where Pseudomonas is going to start to pop up. This is where we start to get concerned about those kind of bacteria. And you notice we're starting to broaden out our coverage in terms of the antibiotics we're going to be using to cover this stuff. So who is going to be at risk for certain types of pathogens? Well, looking at resistant strep pneumo, older patients tend to be at risk for this. How about they had a beta-lactam within the past 3 months? Why does that put them at risk? Because you're putting selective pressure on those bacteria, right? So again, if they've gotten antibiotics recently, they've usually put selective pressure, gotten rid of the susceptible strep pneumo, and they've given a platform for the resistant ones to start to grow again, right? And so that could put them at risk. Alcoholism, immunocompromisation can all lead to that as well. And then a lot of comorbidities, chronic comorbidities like renal insufficiency, diabetes, things like that. And then exposures to kids in daycare. Why would that be a likelihood to get more resistant strep pneumo? So daycares are little cesspools of bacterial growth, and in fact, I think if the zombie apocalypse ever comes about, it's probably going to be from a bug that was hatched in a daycare center. Because again, they get sick and they give it to their friends, and they give it to their friends, and they get put on antibiotics, and then they grow out resistant strep pneumo, and they give it to everyone. So this is one of those things where you're going to see a lot more resistant bugs happen there. And so if they have family members who are in direct contacts, grandma's going and dropping them off, things like that, they could be more at risk, right? And so things that might put them at risk for, say, an enterogram negative bug, things like residence in a nursing home, things like having underlying medical comorbidities or cardiopulmonary disease, and then again, recent antibiotic use will also put that selective pressure on there and make it more likely for that to occur. Okay, and how about Pseudomonas? Obviously, why do we care about Pseudomonas? It's a pretty nasty bug, and we need to do, what do we need to do in terms of antibiotic coverage for that? Remember we talked about that? We have to do double coverage, right? Remember, there's only certain antibiotics we could use to actually cover that. So we'll mention that in just a little bit. Why corticosteroid use? Why would that put you at risk for Pseudomonas? The immunosuppressant, absolutely, right? Broad spectrum antibiotics, say more than 7 days in the past month, malnutrition, all these things, again, put them just at greater risk. So in terms of treatment for community-acquired pneumonias, if they have no risk for resistant strep pneumo, certainly you can start off with a macrolide. You're much more likely to get one of those like chlamydias or mycoplasma, something like that. This is where we can end up utilizing macrolides like azithromycin, clarithromycin, easy peasy, no problem, right? So you can give them a Z-Pak, that's totally appropriate for those patients there. As an alternative, if you could not use one of those, or maybe they couldn't tolerate it, that's where doxycycline and minocycline is a good alternative as well. Right? Doxycycline is super cheap. However, we do know there's some problems with that, like photosensitivity, and you worry about in pregnant patients and little kids and things like that. So certainly macrolide tends to be the easiest, especially Z-Pak dosing is quite simple. They do have risk factors for resistant strep pneumo. That's where it gets a little bit more complicated because now you still got to worry about the atypical bugs, but now you got to have coverage for that strep pneumo. And so frequently they'll use like a beta-lactam plus a macrolide. So for instance, they'll use amoxicillin, maybe plus or minus clavulanic acid, depending on where you're working and the susceptibility rates to that. And then, or as an alternative, you could use something like ceftriaxone, cefpodoxime, second or third generation cephalosporin. Use one of these plus azithro or plus clarithromycin, right? Or instead of that combination, you could just use a fluoroquinolone. However, be careful because certain fluoroquinolones are going to be more or less resistant to that strep pneumo, so you don't want to use something that's not going to work. Like a ciprofloxacin may not be appropriate for those cases there. But if they could not receive a beta-lactam for one reason or another, this is where fluoroquinolone is going to come into play here. Okay, so usually levo, moxifloxacin tend to be a little bit better coverage in those cases. If they're coming inpatient, this is where we're going to start to switch over. And again, if they're sick enough to warrant coming in-house, you want to start them off on PO or IV antibiotics. IV, right? Typically. We'll start them off on IV. And actually, we're going to use a combination here. You'll find that IV macrolides are not used super commonly, so you may start the patient off on oral azithro plus like an IV beta-lactam, something like that. But typically we'll use something like either cefotaxime, ceftriaxone, or maybe like a high-dose ampicillin, plus that macrolide. So one of the beta-lactam drugs to kind of get cell wall activity, and then you have an oral macrolide to get those atypicals. Now, ceftriaxone, what's the nice benefit of using that? Easy dosing, right? Do I have to worry about renal function with ceftriaxone? Do I have to worry about renal function for a lot of the other beta-lactams? Yes, you do, right? So especially as older patients may have poor kidney function, ceftriaxone is a godsend, right? Because you just say 1 gram Q24 IV, done, right? Don't have to worry about it anymore. May not always be appropriate for your patients, but for the large majority of them, it's going to be pretty reasonable there. So you could use that with some macrolide, or you could use something like doxycycline, or you could use something like a respiratory fluoroquinolone if they are not good candidates for that beta-lactam. Okay, so again, it's a combination, or doxy, or fluoroquinolone. Okay, if they're going to the ICU, again, they're even sicker than if they're just coming in-house, and so they're going to require, again, all IV treatment at that point, and this is where you also have to consider MRSA coverage if warranted, so we can use something like vancomycin, as we mentioned. What's an alternative to vancomycin? Linezolid, good. What is another alternative? Ooh, Dapto. Can we use Dapto in the lungs? As you recall, we cannot use Dapto in the lungs because the surfactant actually inactivates it. Okay. So if I were to ask you on a test and I said, hey, patient's got community-acquired pneumonia, is going to the ICU, they need coverage, blah, 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 for MRSA, which one of these drugs would be contraindicated? And you would say daptomycin, right? We'll get more details on those in a few moments here. Certainly community-acquired MRSA rates have been on the rise in recent years, and you may suspect this more if you say, for instance, find like more cavitary infiltrates on chest x-ray in a patient with aspiration, or without aspiration, as I should say, or if they've recently had the flu, those patients tend to be more susceptible to getting an MRSA infection here, especially if on the gram stain comes back with a bunch of gram-positive cocci and clusters, that kind of will clue you in as well. As I mentioned, either requires vancomycin to begin with, or linezolid as a backup. Now, vancomycin, what do we know about dosing for that? Is it Yeah, we have to do like therapeutic drug monitoring on it. Do we have to do, what kind of monitoring do we do for that? Troughs, peaks? Troughs only, right? We'll get back into that and talk about why that is. How about how it's eliminated? It's all renal, right? Again, the benefit of something like Zyvox is that it's very easy. It's 600 milligrams Q12, same dose IV or PO, very simple. However, it's more expensive, and we want to hold off on using that. How come? Because if the patient comes back with VRE or VRSA, I'd like to have something held back that I can pull out when need be, right? So this is like vancomycin's like the paper plates like everyone gets, and like Linase is like the good china they only bring out when like nice people are over, right? Get married, you don't know what I'm talking about. You have all these plates, and I'm like, why can't I use this? We're out of paper plates. Or I'm out of like clean plates. And they'll say, no, you can't use that. It's only when company comes over. I said, okay, I guess we're not going to use these plates. No linazolid for me. I'll eat out of the container. No. So switching gears, right? So that was community-acquired pneumonias. Going to nosocomial pneumonias. That means what? We gave it to them, or they got it from a healthcare sort of setting here. Again, this is going to be infections that happen usually 48 hours after admission, right? So it's pretty clear that it's something that they got from the hospital setting and not necessarily from the community, right? And so this includes both your hospital-acquired pneumonias, your ventilator-associated pneumonias, right? And then healthcare-associated pneumonias. What's the difference between hospital-acquired and healthcare-associated? Healthcare-associated. Hospital-acquired just means you get it from the hospital. Healthcare associated means you get it from anywhere associated with the healthcare. So if they live in a nursing home, if they go to a dialysis center, if they frequently go to an infusion center to have medications given, if they're on active chemotherapy, so, these are all things that are healthcare associated, right? So they're constantly in contact with the healthcare environment. That's what's leading them to get these resistant bacteria. Okay, and actually this is the second most common infection seen after hospitalized patients. Or I'm sorry, in hospitalized patients after UTIs, right? Again, why do people get UTIs in the hospital? They have catheters in, right? Anytime you have this foreign material entering the patient, it serves as a very good vector for the bacteria to kind of move on in as well, which is why ventilator-associated pneumonias are such a concern, because we mentioned the lungs should be sterile, but now we have a big plastic tube going down their throat. Guess what? Bacteria can move in as well. So again, this is going to be a big concern for those patients. Why oral health care is so important if they're intubated, because you want to try to keep as many of those bugs out as best you can, okay? And again, you think Medicare or Medicaid want to pay for healthcare-associated pneumonia or hospital-acquired pneumonia? No, they got that while they were in the hospital. They came in for a broken leg, and now they got a pneumonia on top of it. That's on you to pay for. So that's why infection control is such a big deal in the hospital, because it's a big cost savings overall. Right? It's better for your patients and better for the hospital. So, as I mentioned, anyone who's getting recent IV antibiotics, nursing home, chemotherapy, wound care, any of these patients here are all going to be considered to have healthcare-associated pneumonia, and your threshold for worried about multi-drug resistant bacteria automatically goes up for these patients here, right? So certainly there are unmodifiable risk factors and modifiable ones. Unmodifiable ones include things like their age, right? Patients may lie about their ages, but they cannot actually change their age, unfortunately. Certainly things like large volume aspirations, they're hospitalized during flu season, all these different things put them at risk. Certainly modifiable things that we can do is one, try to get any kind of foreign material out of them. So if we can get them off the ventilator, that's going to be beneficial. ICP monitor, anyone know what that is? We're monitoring for insane clowns. Should any show up, we want to make sure we get rid of them. Just kidding. Insane clown posse, if you guys are not familiar with that. Anywho, it's an intracranial pressure monitor, right? So again, it's another invasive bit of monitoring that could be a spot for bacteria to get in. This was interesting. We haven't talked about GI drugs yet, but H2 blockers or antacid therapy. These are drugs meant to either neutralize or prevent the stomach from producing more stomach acid. Why would that put a patient at risk for developing a pneumonia? So if you give someone something that either neutralizes or get rid of that stomach acid, normally the stomach should be relatively sterile, correct? Because such a harsh environment, the pH of 2, that stomach acid basically kills everything off, except for, bacteria likes to grow there, H. pylori, right? So normally it's pretty sterile. If I give them something that blocks that ability to produce that stomach acid, what you're going to find is the bacteria then start to grow, and then they can have these microaspirations that can lead to something like a ventilator-associated pneumonia, okay? The problem, though, is why would we give these patients an H2 blocker or something like that while they're intubated? Because they are chronically stressed, they're like really critically stressed, and so their adrenal glands are pumping out cortisol, And so it's a strong anti-inflammatory. What does that do to prostaglandin synthesis? Does it decrease it, increase it? What happens when even NSAID? Decreases prostaglandin. Well, corticosteroids are doing the same thing from even higher up, right? You don't even get to the arachidonic acid point. So you're decreasing prostaglandin synthesis. Prostaglandins are really important for performing that nice mucus barrier that prevents you from digesting your own stomach. And so if you lose that, because all this cortisol floating through the bloodstream, guess what happens to your stomach? It starts to auto-digest itself, and you get peptic ulcers, you get peptic bleeds that can happen because of that. So there's a balancing act. We have to make sure we keep the stomach healthy, but also we know that that's going to increase the bacteria growth that happens there. So again, it's kind of a double-edged sword in a lot of those cases, and you have to carefully balance it out. That's where good oral care with like things like chlorhexidine swabs and things like that, very, very important for those patients, right? And again, obviously you can limit previous antibiotic use, limit reintubation, all those things are going to help out as well. So let's look at the bugs that we were concerned about with a nosocomial pneumonia. Gram-negative bacilli are going to be a big one, so things like their E. coli, Klebsiella, Acinetobacter, and then obviously Pseudomonas is one we're most concerned with. It tends to be one of the more common ones you're going to run into. And also, what's kind of the bad thing about gram-negative bugs, like in terms of resistance? I like to kind of spread it around amongst one another. Remember, like, so for instance, you could have Pseudomonas that's producing a Klebsiella producing carbapenemase, right? Remember what a KPC does? Carbapenemase would then destroy carbapenems like your marrum and things like that, right? So these are things we were concerned about with these gram-negative bacilli. They like to kind of share their little secrets with one another, and then they get to then be more resistant to some of our drugs. Common gram-positive cocci, certainly strep pneumo, but MRSA is the most common one we're also concerned about treating as well. And then certainly you can maybe start, really broad empiric therapy for these patients here, but the white count's not really changing, and their fever's not coming down, they're still sick, still a little hypotensive, and then nothing's happening. Well, what could it be? Well, it could be something non-bacterial, right? So it could be a fungal pathogen, maybe you have some kind of acid-fast bacilli, like maybe TB is there. Could have all kinds of things, and so that's where you have to start to kind of work up other potential diagnoses and maybe treat that as well with antifungals and whatnot. So typically with a nosocomial pneumonia, start as early treatment as possible. You don't want to wait for a definitive culture, but certainly get those cultures prior to antibiotic use. Why is that? You want to make sure you can actually grow something out if it's present, right? If you give antibiotics first, that may prevent that from occurring, right? And then we initiate broad spectrum coverage. And we'll have to consider, do we need to worry about multi-drug resistant pathogens or not? And we'll talk about that in just a few moments here. Most of the time that we're going to be covering for MRSA and Pseudomonas if we are worried about these pathogens, okay? Once we get those cultures back, then what do? Streamline down, right? So if it comes back and it's only growing Pseudomonas, then I only need Pseudomonal coverage. If it comes back and it's growing MSSA, well, guess what? What can I stream it down to? Dicloxacillin, oxacillin, nafcillin, those anti-staphylococcal penicillins. Like, there's a lot of different options that are there once those cultures actually come back. So if you're worried about one of these nosocomial pneumonias here, you're going to look at their risk factors, right? So if they have a late onset, so say like greater than 5 days after admission, if they have previous antibiotic use, some patients end up being colonized with a bacteria, right? So for instance, we have a lot of like cystic fibrosis patients, excuse me, they're colonized with Pseudomonas. Some patients with trachs will be colonized with certain bacteria. They are also going to be at risk for multi-drug resistant infections. Hospitalized, chronic care, immunosuppressive therapy, all these things are going to be putting them at risk for these multi-drug resistant bugs. So you have to broaden out your spectrum of coverage pretty significantly in those cases. If not, they don't meet any of these criteria, then you can use a little bit more limited spectrum. So if they don't have those risks, then start off with something like ceftriaxone, right? Good broad spectrum, third generation cephalosporin. Very good for most of those patients there. Or you could do something like levofloxacin or moxie. If you're more worried about atypical pathogens, this would be a good one to start with, right? So again, if you really think it could be something like a mycoplasma, Legionella, things like that, this is good. Or you could do something like ampicillin sulbactam. Remember, sulbactam is what? Beta-lactamase inhibitor, right? So it's going to have to broaden the spectrum of coverage. This is really good if you're worried about an anaerobic infection, because again, that beta-lactamase inhibitor helps to broaden out and give more coverage for things like B-frag and things like that. Or we could do something like ertapenem. What kind of drug is ertapenem? It's carbapenem, right? This one is good to use for if you're not really worried about Pseudomonas, because this has the least Pseudomonal activity out of the bunch there. Okay, we'll make mention of that in another slide. So a lot of patients, though, are going to require those broad spectrum coverages. The reason why they're in the ICU is probably because they're pretty sick to begin with, and they probably have a lot of the criteria that put them at risk for an MDR pathogen. And so in these cases here, what we're going to find is we're going to have to use 2 drugs to cover Pseudomonas. We're going to get 1 drug to cover for MRSA. Okay? So when you're covering for Pseudomonas, you're going to need 1 cell wall active drug and then a different drug with a different mechanism. Okay? That'll become more clear in a second here. So that means that your first drug is going to be either an anti-Pseudomonal cephalosporin, such as cefepime is going to be pretty much your go-to for the majority of the time. A anti-Pseudomonal carbapenem, such as imipenem is one, meropenem would be another one, doripenem would be another one, right? Those will all be fine. Or an anti-Pseudomonal penicillin beta-lactamase inhibitor, which is piperacillin tazobactam, otherwise known as Zosyn, right? So very frequently find cefepime, Zosyn, those are the more common ones. We typically try to hold back on the carbapenems as best we can because, again, we like those for those really resistant bugs, especially the ones that produce the extended spectrum beta-lactamases, losing activity of things like Zosyn. So that's where our carbapenems are going to come into play. So you're going to use one of those, plus either an anti-Pseudomonal fluoroquinolone, so like levo, most of the time it's going to be levofloxacin, sometimes Cipro, or an aminoglycoside. So the fluoroquinolones work how? Inhibit topoisomerase and DNA gyrase, right? So they're causing strain breaks in the DNA, whereas the aminoglycosides did what? Protein synthesis inhibitors, right? Now, I know it's been a long time since test 1. However, it's good to remember some of this stuff, and so it may behoove you to go back and review some of that material, right? It may bug you to do so, but it may be necessary. Anyway, so you got 2 of those drugs, right? 1 cell wall active drug, 1 drug via another mechanism, and then we're going to have 1 for our gram-positive coverage. 95, 98 times out of 100 is going to be, everyone together, vancomycin, absolutely. So vancomycins are the go-to. Now they'd be IV or PO? IV only. Could you give it PO?
You can, but it doesn't help.
What is? Yes, it's only PO vancomycin's only for C. diff. IV vancomycin's for everything else, right? Or as an alternative linazolid, you could use daptomycin, not in the playlist here, right? So now, certainly talking about anti-Pseudomonal cephalosporins, ceftazidime has been used in the past, but it is something that gets a lot of resistance, so we don't really do that too frequently. Cefepime, though, is kind of your workhorse one, right? It's going to be one used very frequently. We talked about it being used for things like febrile neutropenia. We use it for this. Very good anti-Pseudomonal drug here. The nice thing about it as well is it doesn't really cover a lot of anaerobes, so if I'm not worried about anaerobes, then this is a good one to go with, versus someone like Piptazo, a lot more anaerobic coverage and maybe unnecessary for the case here, right? Again, both of these require renal adjustment. And when these patients are coming in and they have a nosocomial pneumonia and they're really that sick and they're in the ICU, are their blood pressures usually pretty high or low? They are going to be trending towards low, especially if they start to develop SIRS and sepsis and all this fun stuff. And so what organ is going to get underperfused? The kidneys, and thus we worry about their renal function, right? So how do I monitor for that? Serum creatinine, right? But remember that takes time to monitor for that because it takes time for them to get to a new steady state once you have a kidney injury. The easier thing to look at acutely is urine output, right? So again, if your patient's peeing out, say 1.5 mLs per kilo per hour for the past 5 days, and all of a sudden it goes down to, say, 0.5 mLs per kilo per hour, that should go to show you, okay, something's going on here. Why are they not producing urine? Are we not giving them fluids? Are they dehydrated? Or is it because the kidney function just take a hit? And then the next couple of days or so, you'll start to see the creatinine start to rise up as well, right? So in those cases, then you have to go back and readjust your doses to make sure they're getting in appropriately. For the carbapenems, this is where you have imipenem, cilastatin. Now, who would this not be good in? Seizure history, right? Especially if you're not accounting for that change in renal function, they're building up levels. Seizure can be a big risk with that one. Meropenem, less risk. This is probably the one I've seen used 10 times out of 10. The last time I saw imipenem, I think I was an intern during my first year of pharmacy school, so it's been some time, unfortunately. And then ertapenem is kind of the least amount of activity against Pseudomonas, so that would not be an appropriate choice here. But certainly doripenem would be another option that could be good, right? Then for the anti-pseudomonal penicillins, ticagrelor's another one I haven't really ever seen used clinically, but certainly piperacillin tazobactam is going to be the drug of choice in that case there, right? Especially if you're worried about any kind of anaerobes, then that would be good to cover that. Most of the time, though, I'd kind of get providers to try to use cefepime if that's more appropriate in those cases, right? But again, all of these require renal dose adjustments. You got to go back and review those and see if you need to change that up based on how the patient evolves over time. Now, into our anti-pseudomonal fluoroquinolones, you're going to see things like Cipro, levofloxacin are going to be good here. Notice Moxie is not going to have great coverage, right? Even though it does cover your atypicals, it's going to be marginal in terms of its coverage against Pseudomonas here. Even Cipro might be not a great first option. I see most people tend to go Levo over most other things for the most part. But again, it will be good if they have something like Legionella or Mycoplasma kind of growing in addition to whatever else are growing there, like Pseudomonas or MRSA. Also, it has good lung penetration, which means that the drug you do administer will have a good ability to get to the lungs to actually treat the infection itself. The lungs, not as bad as the CNS, but tend to be a little bit more difficult to penetrate, and so that's why you have to sometimes shoot for higher levels for drugs or give bigger doses, just because it's harder to get in there and actually get those bacteria covered. And so, again, as we are starting to see more and more resistance, especially from Pseudomonas, these are not going to be used as frequently. However, they do require renal dose adjustment. Also, what other kind of patients would fluoroquinolone be a bad choice in? Pregnant. Who else? Elderly. Why elderly? Yeah, CNS toxicity. You can see with them altered mental status, which again, most of these patients, older patients coming in with pneumonia, where they're going to also be presenting with altered mental status as well, right? So again, you can't tell if it's the drug, is it the infection they have, is it just because their dementia is getting worse, is it because they're in the hospital instead of their normal home? What could be happening here, right? Also, who else? Kids typically. Why kids? We're about tendinitis, Achilles tendon rupture, things like that. Not to say we never use fluoroquinolones in that age group, but certainly is a risk we want to be at least cognizant of, right? Also, it causes QT prolongation, right? So these are all the kind of things you want to keep in the back of your mind to see, is this a good, appropriate drug for this patient or not? And then far and away, the most common thing you end up running into is probably going to be an aminoglycoside. So the most common regimen I would see would be something like either cefepime or piperacillin tazobactam. So you get one of those cell wall active drugs. You get an aminoglycoside like Gent or tobramycin or amikacin plus vancomycin. That 3-drug regimen is super, super common because that covers all your bases there and will get most of what you're trying to cover, okay? Now, if you recall, the aminoglycosides are a time or concentration dependent killer. Concentration, right? What kind of sets concentration antibiotics apart from the time dependent? Yeah, remember that post-antibiotic effect, right? So even if the levels drop below the MIC, they still continue to kill off that bacteria. Aminoglycosides do that, so this is why we give really big doses. We just give Q24-hour doses, and then we will go ahead and make sure the patient clears all that out before we give the next dose. And again, when I monitor levels for this drug, do you think I do peaks or troughs? Troughs. Why am I doing that? To make sure they clear, right? So I'll give them a dose or two. Before that 3rd dose, I'll get a level, and it should be undetectable, right? So it should say, usually when labs report things as undetectable, anyone know how they normally report that? They'll typically say less than a certain threshold, so it may say less than 2 mics per ml or less than 0.5 mics per ml. Depends on the lab that you're running there, but that essentially means that it's undetectable. They couldn't find it on the lab. And that's a good sign, right? We want to make sure they're clearing it out. We know the dose they're giving is so big that they're going to get concentration in the lungs that's going to be effective, so we don't have to worry about measuring peaks for those patients there. Why do we even monitor in the first place? Why do we care if they clear the drug? Toxicity, namely renal toxicity, right, which could already be a problem if they're developing sepsis. Oh my goodness. Everyone's awake, right? So you want to make sure that if their kidneys are possibly taking an injury there, like this could exacerbate that, right? Also, with the patient's intubated and sedated, are they going to be able to tell you that their hearing is getting a little fuzzy? No, they're not going to be able to, right? So those are things we want to make sure they're not accumulating levels of and not eliminating. Now, vancomycin, again, if you remember the structure of vancomycin, remember it's like kind of big, kind of small? Big, right? That's why it doesn't get absorbed from the GI tract. It's so big, can't cross over. Well, this is also another reason why it has a hard time getting into the lungs. And so, for instance, if I was treating, say, a simple cellulitis or a bacteremia, I could maybe shoot for a trough level for vancomycin, say 10 to 15 mics per ml. Well, for this one, I got to shoot for 15 to 20, right? So it's a higher blood level, should correlate to a higher level in the lungs, correct? And so that's why I end up shooting for those higher troughs in those cases there. And now, is vancomycin time or concentration dependent? Time dependent, right? So why do I measure a trough? make sure it's staying above the MIC, right? So as long as I'm keeping it between 15 and 20, it should have levels in the lungs that are staying above the MIC for the bacteria and make sure they're continuing to kill it off for the whole 24-hour period, hopefully, okay? Now, I measured prior to the third or fourth dose, and why would I do that? To get a steady state, right? It takes about 4 to 5 half-lives, so this is why we give it a little, before third or fourth dose, get a level. It should be a steady state at that point, because if I get too early, what happens? Looks too low or too high? Too low, right? So we'd falsely say, hey, well, the level's too low, let's go ahead and bump up our dose, and then what happens when you finally do get to steady state? Trough's too high, right? And then we start to worry about toxicity, namely, just like the aminoglycosides, renal and ototoxicity. So again, sometimes it's hard to tell. Was it the vanco? Was it the gentharon? Was it because they have sepsis and that's why their kidneys took a hit? Oftentimes it's multifactorial and it's really difficult to determine which one was causing the problem there. So again, just be aware of that. Vancos itself is usually pretty okay on the kidneys. It's when you combine it with things like furosemide and you start to include it with gentamicin and all these other nephrotoxins, that's where you really run into problems with those patients. And then linezolid, as we mentioned, is a good backup. Now, aminoglycosides, vancomycin, very renally dependent. You got to really watch those doses there. Make sure they're giving the appropriate frequencies for those patients. Again, who's your best help in making sure those patients are dosed appropriately? Besides yourself? Your local pharmacist, right? So this is why I really recommend making good friends with them and say, can you please just dose all my antibiotics? And they'll say, oh, I guess so, yeah. No, but say, for instance, they have the day off, they're taking a vacation, and you're by yourself, or if in the middle of nowhere and there's no pharmacy services to see, you're not going to call me up and say, nah, you got to do this on your own. You got this. They'll hang up. So again, knowing how to do the therapeutic drug monitoring, knowing how to interpret those levels, very important for you to do, right? Anyway, but linezolid is an easy fallback because you don't have to worry about renal dose adjustment, anything like that. It's just 600 milligrams Q12 and you're done. Either IV, PO, no problem. However, we like to hold it back because again, it's one of those things where we want to save it for the VREs, the VRSAs, all those really scary bugs that vancomycin is not going to cover, okay? It's also more expensive, so from that standpoint as well, oftentimes in hospitals, you may order linezolid, but then when do you get a call from? Who do you get a call from? From the pharmacist, right? Maybe on the outpatient side, but on the inpatient side, you're going to get a call from the pharmacist saying, like, what are you doing? And you say, well, I'm using linezolid. And I'm like, why do you want to do that? And then he's like, because they have bad renal function. And so that may be an appropriate use case in some hospitals. In some places, you may have to get approval from infectious disease. Just depends on what their stewardship programs are like. So for instance, at Nemours, if I have a patient or I have a doc or somebody orders linezolid, they're probably going to be they probably have already talked to infectious disease, but they're usually the people that are the gatekeepers for that stuff. So it's not that we want to prevent you from doing what you want to do, right? But to make sure that we're using things economically, making sure we're doing things appropriately so that way patients down the road still have effective antibiotics. Okay, so further therapy, right? So ideally we'd like to scale back therapy once those cultures come back. Again, if it shows, say, E. coli that is susceptible to ceftriaxone, but they were on piptazo, vanco, and gentamicin, what do I scale back to? Ceftriaxone, right? If it's susceptible, that's the only bug that grew out, guess what? I can just scale back to that, and that's totally appropriate, right? It's called de-escalation of therapy. You may be scared because you're like, well, what if something didn't grow out? What if? That's not appropriate, right? You want to go ahead and de-escalate, make sure. And again, as long as the patient's white count's coming down, their fever's coming down, they clinically are improving, then it's totally okay to de-escalate in those cases there. Obviously, we'd like to switch over to PO when possible. Why do you think we do that? It's cheaper, and what else? Well, compliance should be 100% because the nurses presumably are doing their jobs, right? What happens when you have a catheter inserted into the patient's veins? Infection risk, right? So again, the sooner you can get them off of their IVs, the lower that risk from them getting a bloodstream infection due to that, right? It's another big infection control thing we are watchful for in the hospital. Now, if they're failing therapy, what could be some reasons for that? Well, maybe we picked the wrong drugs, right? Maybe we picked the wrong regimens, and maybe we didn't include vancomycin when we should have, right? What are some other reasons? We're giving the wrong doses. Maybe we didn't get up to a therapeutic concentration for, say, a vanco or something else, or maybe we're giving it too infrequently, potentially. What are some other reasons? Resistance could be one, right? It could be giving them vancomycin and it comes back VRSA. Well, yeah, obviously that's not going to work, right? What other things? Well, these are mostly IV agents we're given because these are the really sick nosocomial pneumonia patients. So that oftentimes would not be a concern, but it is a good thought if they were getting like oral doxycycline or something, right? What else? What? Maybe, yeah. There's not too many CYP interactions that we've come across, at least with the agents we're using here, but definitely a good thought. What if it's not a bacteria? Right? So it could be a fungus, it could be, acid-fast, mycoplasma like tuberculosis or something like that. So those are all considerations you want to make there. Often, or it could just be the wrong diagnosis, right? So if someone presents with chest pain and dyspnea, may look like a pneumonia, but then it could be a PE as well, right? So these are other things that could be potentially presenting there. So other things to be concerned with, or at least think about. And certainly complications, C. diff is always a big one. The more broad spectrum you go, the more likely you are to disrupt that gut flora. And so that is a big concern, but certainly lung abscess, empyema, things like that can also occur as well. Now treatment should be about 7 to 10 days or so. However, if you have one of these more resistant gram negatives like Pseudomonas, Acinetobacter, things like that, then you extend it out usually 10 to 14 days, okay? And that's how mainly you manage pneumonias. Any questions on that? I want to talk about tuberculosis. This is a sore subject for you guys, but okay. Let's talk about the meds that we're going to use for tuberculosis. These are kind of interesting ones. So what's kind of unique about tuberculosis versus, say, like other normal bacteria we treat in a typical course of things? So one, it's very slow growing, right? We mentioned that things that are fast growing tend to get affected by our drugs more quickly, right? More easily. What else? So it has this nice kind of layer around it that kind of prevents the drugs from working all that well, that kind of mycolic layer. What other things? It persists for very long times in an inactive state and then activate later on. So there's a lot of things about it that make it kind of unique, which is why the drug therapy is going to change it's going to be much different than what we would see with like a typical single organism bacterial infection, right? As mentioned, it's an acid-fast bacilli, and if you were looking at, how long does a normal bacterial culture take to come back? A couple days or so, 2 or 3 days. You should have some, preliminary results. Maybe you'll get the final sensitivities back after, say, 5 to 7 days, something like that. How fast do these come back? So they're slow growing, so they do take quite a while, right? So again, oftentimes you may be treating empirically. Say you have a patient you're treating for a pneumonia and they just aren't improving, and this is a consideration. And so until we get those cultures back, sometimes we have to treat them empirically until proven otherwise, right? That's more like the ICU inpatient sort of side of things. But other things, we're going to see this mycolic acid layer that forms this waxy cell coat, which can make it very difficult for drugs to penetrate. And typically, if you're actively treating tuberculosis, how many drugs are you typically using at a time? 4 is pretty common, maybe 5 in some cases. We'll look at some instances where you might use one versus the other. 4 is pretty common though, but again, because it is so slow growing, you're going to find the antimicrobials that affect cell division, right, are not going to work quite as well there. So again, a lot of things are kind of working against us in these cases here. Now, I'm going to mainly just talk about mycoplasma, or mycobacteria tuberculosis, I should say. So just keep in mind that some of this will apply to some of the other ones, but TB is the main one I'm going to focus on because it's probably the most common one you're going to run into, right? So anyway, so tuberculosis, leprosy, certainly caused by that. We learned what animals can cause leprosy. Armadillo, right? Armadillos can certainly do that. Mycobacterium avium complex is is actually an AIDS-defining illness. So patients with HIV with low CD4 counts, usually like less than 50, tend to be at risk for MAC. Happens there. And lots of other types, but I'm mainly going to focus on the Mycobacterium tuberculosis, right? It's the main thing. So looking at treatment, we'll get into individual drugs here. You can kind of see the range is you just kind of start kind of fast and strong with 4-drug regimen in a lot of cases. Do that for say like 2 months or so, and then you can sort of back off. But notice the treatment durations here, quite long, right? And what kind of patients are at risk for developing TB? Compromised patients. Who else? Homeless patients. Right? Patients who are in confined spaces like jails, prisoners, things like that. So, as you might imagine, what do you think compliance is going to be like for some of these patient groups? Great, right? So again, this is one of those things where we may try things like direct observed therapy, where actually try to make sure we can see them take their medications to make sure we're enforcing compliance. But it is a problem, right? Because what happens if they get, say, a month into treatment and then they stop? well, it's going to be more resistant potentially when it comes back, right? And so you also don't eradicate the infection in that patient, and they go on to spread it to other people, right? So this is a big concern. But we're going to mainly look at these drugs here: isoniazid, rifampin, ethambutol, and pyrazinamide. We'll look at a few others as they become pertinent. So, as you mentioned, for instance, like a pulmonary tuberculosis, 6 to 9 months or so is a typical treatment time, right? So, a 4-drug regimen initially, and then you kind of scale it back. But again, compliance is a huge problem for this because it is so slow growing there. Patients who are immunocompromised tend to be even longer, or if it gets complicated other body parts, again, even longer than that. To 2 years of treatment, that's a long, long time. Imagine starting a medication when you start PA school and you finish it when you graduate, right? Seems like forever already, doesn't it? Yeah, exactly. So this is also why we use combination therapy, because we know by using single agents, you're more likely to end up helps to prevent resistance in those cases. Okay. So the main thing I'm going to focus on are these drugs in terms of like what are the kind of unique side effects you're going to see with them, what potential interactions you might run into, things like that. So isoniazid is one of the first one here. No, it depends on if the TB is more in a sort of actively dividing state or not. It can be both bacteriostatic or bactericidal, as the case may be. And this one actually works by inhibiting that kind of that waxy cell coat from forming there. So what is it going to do for our other antibiotics? It'll help with the penetration, right? They're going to be able to get in better to help prevent the growth of that TB, right? And so note here that roughly 75 to 95% of it excreted is acetylated metabolite. Wait a second, acetylation. I know something about that. What can happen with acetylation? You have slow metabolizers, and you can have fast metabolizers, right? And so again, depending on how the patient will excrete it or how they're metabolizing it, what do you think it does to potential for toxicity? It increases for who? Slow metabolizers, right? However, the fast metabolizers might need what? Maybe need higher doses, right, potentially. And so this is important because there are kind of unique side effects with isoniazid that are important to be aware of, right? And so anyway, again, how we see a lot of these absorption or resistance patterns develop is actually due to mutations in the DNA start to change the activation enzyme, and thus it makes it less effective when actually trying to treat that TB. Other things that are nice is has good bioavailability, good oral bioavailability, and also enters the CNS in case you had any of those kind of extra lung sort of complications there. So, as I mentioned, can be used prophylactically by itself potentially. If you had, say, a close encounter with the TB kind, perhaps you can start that for a short period of time. Or in some cases, you'll have, for active disease, you use combination therapy. So it's part of that 4-drug and the 2-drug regimen there. So again, side effects we're worried about. If you have a slow metabolizer, slow acetylator, you still have to worry about that lupus-like syndrome, right? What other drugs do we see that with? Hydralazine was the other one we covered like 2 days ago. Procainamide, right? Procainamide, hydralazine, and isoniazid are the 3 most common drugs that's going to cause that lupus-like rash. When you get that question on the boards, you say, gosh darn, I'm so glad Dr. Wood taught me about that, right? Because it'll come up. Anyway, so that's one concern you're going to have with this. Certainly in patients with history of liver dysfunction, alcoholics, things like that, you're certainly going to see some liver toxicity associated with this drug. And then other kind of unique things you're going to see with this includes peripheral neuritis. This is actually due to the fact that isoniazid prevents the activation of pyridoxine, and pyridoxine is important to help kind of keep those nerves healthy, and when you lose that, you end up developing a peripheral neuritis, and it kind of has what kind of distribution? The most distant nerves get affected, so you get a glove and stocking distribution, right? You see the peripheral neuritis, so they start to complain of like pins and needles and paresthesias and things like that. Typically the hands and the feet are going to be the most common things that end up getting affected by that, right? Anyway, what's also interesting as well is that B6 is really important, pyridoxine is really important for the production of a neurotransmitter. That neurotransmitter is GABA. You know what GABA does? It's a main inhibitory neurotransmitter, so it's kind of like the brakes on the system, right? I said adenosine is like the emergency brake on your car. GABA is like the normal brake on your car, right? And so if you inhibit that process of forming GABA, what do you think happens? Well, you lose the brakes. What would happen if you lost the brakes on your car? You just keep going, right? You couldn't stop, and so that could lead to things like crashes, or namely in the terms of your brain, seizures can actually develop there. So if you lose the ability to inhibit those neurons from firing, from hyperpolarizing, you end up developing seizures. And so this is actually a case here where patients, there's been case reports of patients who actually overdose on isoniazid and they have intractable seizures. You give them all the medications you want, nothing fixes it. And guess what we give them to fix the seizures? big dose of B6, right? You get a 5-hour energy, hook it up to an IV. No, I'm just kidding, you don't do 5-hour energy. We just have B6 we can administer IV, a big 5-gram dose. It goes in and it fixes the seizures, because now they can start to form GABA again due to kind of overcoming the isoniazid effect. Anyways, trying to link that back to show you why that causes seizures is because of that pyridoxine deficiency that it induces. Okay, but before that, you can also see things like psychosis, memory impairment, etc. Right? Now, did we talk about isoniazid? Just kidding. Memory impairment, right? Just kidding. Now, wait a second. He actually loses mind? Quite possibly. Now, we've talked about rifampin before. Where did that come up? Yes, endocarditis, right? And it turns you orange, right? What does it turn your urine colored? Orange, red, discoloration, right? So a very bright red, actually kind of a dark red, almost looks like wine or port or something like that when it's hung up on the IV. But yeah, it kind of turns everything orange. Again, that will screw up a lot of labs, because a lot of labs are based off of color readings in terms of like light absorbance and whatnot. And so many labs can actually be affected by that when they start to read more red than they should. Even tears, sweat, anything can be discolored orange in a lot of cases there. So anyway, so this is going to be something that has good broad spectrum coverage there against specifically TB, so it's going to be a good add-on agent. We also thought it was nice for certain bacteria commonly seen with endocarditis, right? A lot of the gram-positive bugs there. So again, not used frequently by itself, and why is that? Resistance tends to be a big issue with this one, right? So remember we talked about rifampin being added on last when treating endocarditis, because we want to get the other agents active first and then allow the rifampin to kind of come in and kind of help out with that, and instead of getting resistant when given early. Now, here we're going to see it works on the RNA polymerase. So it actually helps to prevent that protein production that happens here. Again, it's very specific for the TB cell, so it doesn't really affect us quite so well. And again, not used by itself. Typically, you can either use it for tuberculosis, part of a multi-drug regimen. We talked about endocarditis. Another big place you might see this is for a meningococcal disease that's prophylactic. So if someone develops, say, like Neisseria meningitidis, meningitis, you can use this as a kind of prophylactic. Nowadays, we start to use like more Cipro in a lot of cases, but this has been used routinely in the past. So we mentioned this is going to be a CYP enzyme inducer, right? So what does this do to metabolism of, say, drugs or substrates for those enzymes? Increases metabolism. So it does what to the levels? Decreases them, right? So this is a strong inducer of 1A2, 2C9, 3A4. So it's going to be affecting things like your warfarin. It's going to be affecting things like your statins, certain statins. Also, we mentioned that patients with HIV are at risk for having TB, right? Those opportunistic infections that can pop up there. A lot of their drugs actually go through CYP3A4 metabolism, and actually in some cases, and we'll talk about this next semester, we will give them CYP3A4 inhibitors for the express purpose of boosting up levels of the other antiretrovirals. And if I give this on top of all those, what is that going to do to their antiretroviral therapy? It's going to lower the levels, and then the HIV is going to do what? Start to replicate again. So you can see viral load come up, a CD4 count might go down as a result of that, right? So you have to be really cognizant of these drug interactions and make sure the patient's not going to have any significant drug failure from the antiretroviral side as opposed to just the TB side of things, right? So a lot of effects here. Certainly hepatitis can develop here. So we talk about secretions, tears, sweat, urine, anything will be kind of colored orange, reddish, and because normally if you see kind of reddish urine, pinkish urine, what do you think? Think blood, right? However, this is just going to be the medication. Okay. Some people have hypersensitivities, GI disturbances, but those are kind of the main things you're going to find with that. Next, we have ethambutol. It's kind of like the classic side effect of ethambutol. Yeah, the red-green color discrimination tends to be impaired there, right? I always wonder, like, has anyone ever actually run a red light on accident because they couldn't tell the difference and got into a wreck because of ethambutol? I don't know that that's ever happened, but I always wonder about that. Most people around here obviously don't know the difference between red and green lights anyway. Sorry. Not? No? Are you one of the people that run the red lights all the time?
No.
Huh? Are you colorblind? Oh my goodness. Sorry. But it's more, what kind of color blindness do you have?
It's more red-green, but it's if they're really close, like apples in the supermarket.
So you like bite into like a nice Fuji and it turns out it's a Granny Smith?
Yeah.
Oof. Hate when that happens. Interesting. You know, what I find it actually interesting is that Obviously men are more likely to be colorblind. They actually found a disproportionate share of male video game players tend to be more colorblind than like the general population. There's a correlation. I don't know if there's any kind of causation, but I find that very interesting. Yes. Anywho, thank you for that tangent. I'm sorry I offended you in any way with your colorblindness. My dad's colorblind, actually. So I can say that, yeah. It's okay. I get the colorblind pass. I don't know what color the pass is, but it's gray. Anywho, back to the topic at hand. So we know that thiambutal also works to inhibit that kind of mycolic acid sort of importation to the cell, so it helps to work on that waxy coat as well. It's kind of working in conjunction with something like isoniazid. Again, it gives better access for other drugs to kind of get in there and do their work, something like rifampin or pyrazinamide, as we'll see here in a moment. So again, this one has to be renally dose adjusted, so watch out for that. And again, don't use it by itself because that's where you end up seeing a lot of resistance to these agents, right? So we mentioned the visual disturbances, kind of more limited in kids, maybe see it more in adults here. Decreased visual acuity certainly, but kind of the classic thing you think about, like the board style question you get would probably be that red-green discrimination being impaired for those patients, okay? So when you see that on the boards, glad to remember that, right? Anyway, other things increase uric acid levels. Obviously, watch and monitor for that. Watch the patient with gout, etc. I watch my time, make sure I don't go over. Then pyrazinamide is actually is interesting. It actually alters the pH of the bacteria. It actually lowers it because it gets converted over to pyrazinic acid, and it prevents it from growing. Also helps with enters the macrophages to get kind of phagocytized a little bit easier and to kind of get rid of those TB cells, right? The nice thing with pyrazinamide is it actually shortens up the treatment duration. You kind of go for a little bit shorter period of time by using that combination. And so that's why you'll see it used for the first 2 months and then take it off after that. Some of it due to that treatment duration shortening, also due to some of the liver toxicity you see with it. Okay, no major effects to worry about other than the hepatic effects, the hepatotoxicity you can see with this, and then this is another one we'd avoid in pregnancy. So I mentioned combined therapy typically is going to be at least consistent of isoniazid and rifampin. Usually 18 to 24 months or so, but there's other agents you may use occasionally. I'm not going to get into great detail on these because they're not used as commonly, but just be aware there are certainly other ones that are out there that could be useful. Even like linezolid has some activity against TB, may be seen occasionally in one of those combination regimens. And you'll see as resistance patterns change over time, you may find that some of those drugs will get switched out for and turn into the drug of choice. So could turn out linezolid is a drug of choice in a couple of years, who could say? So any questions on TB? Nothing? TB continued, maybe? Okay, let me see if any questions. Nothing at all. Oh, wow, I got a couple. All right. So, what are the most common drug mistakes PA S2 students make during clinicals? The things I have gotten feedback on, I do try to go back and change classes if need be. When you go to your behavioral rotations, know all those medications. We cover a lot of them. There's always new ones that are coming out, especially a lot of the atypical antipsychotics that we'll cover next semester. But be really familiar with those before you go out on your behavioral health rotation, right? That's probably the biggest one. And then like treatment durations for antibiotics. I know we don't talk about that a lot here, but certainly like in your medicine classes and when you do clin pharm in the summer, kind of key in on how long you're going to be treating different disease states, you know, cellulitis versus pneumonia versus AOM and all the different things, right? Those are probably the common ones. What's it called? A randomized clinical trial instead of a trick or treatment? Yes, thank you. Professor Kaplan sent that meme to me the other day. Go figure. Any other questions? Nothing at all. I will see you guys next time.